Now talking about the Streptococcus. That is the second gram-positive cocci which we'll talk about. Now, first of all, you should know that the Streptococcus is being classified on the basis of hemolysis. Okay. So three hemolysis, you already know what are they: alpha, beta, and gamma. Okay. Alpha, beta, and gamma hemolysis. What is the meaning of alpha hemolysis? Alpha is partial, beta is what? Complete, and gamma is no hemolysis. Is it fine? So in the alpha hemolysis, first of all, which all Streptococcus, they show the alpha hemolysis. So alpha hemolysis is shown by Streptococcus viridans and Streptococcus pneumoniae. Okay. So these are the typical examples of alpha hemolytic strepto. Regarding the gamma, if somebody asks, that is Enterococcus faecalis and faecium. Okay. Enterococcus faecalis and faecium, they are the gamma hemolytic ones. Regarding beta hemolysis, if somebody wants to know, regarding the beta hemolysis, remember this, those particular Streptococcus which shows beta hemolysis, okay, they are being classified into groups A to V on the basis of carbohydrate C. Okay. So they are being classified on the basis of what? Carbohydrate C, and they are being grouped into how many groups? Groups A to V. Okay. And what you do then? You take this group A and divide this further into 80 to 100 types on the basis of M protein. Okay. So M protein and carbohydrate C, they both are in their cellular structures. And this M protein also plays the role of virulence. It also have the role of what? Virulence of the Streptococcus. These particular groups, A to V, except I and J, they say, is based on carbohydrate C. And this particular one, which is being grouped up, group A, into further 80 to 100 types, that is being grouped on M protein. Now, let's know that what's their name. What is the name of the classification? So, carbohydrate C1 is termed as Lancefield classification. So, what you do, you make this C capital. You will able to know that this is dependent on what? Lancefield. Whereas in the M protein stuff, what is there? In them, you remember the classification based on M protein is what? Griffith. That is termed as which one? Griffith classification. Okay. So this particular question comes again and again, that which depends on what. So Lancefield is based upon carbohydrate C and Griffith is based upon M protein. This you need to know. Okay. And how to remember? This particular thing I made up in the Lucknow class of mine. So you remember like this: Lucknow city, good morning. So you can make anything like that. But still, these all things, they stuck to your mind. So that's why I'm saying up. The Lancefield is based upon carbohydrate C and Griffith is based upon M protein. Is it fine? So this particular classification, that is Lancefield and Griffith, they are based upon these particular structures, which also plays the role of virulence in the Streptococcus pathogenesis. Is it fine? Now, these particular groups A to V, no need to remember all the names. What you need to know is what is there in the group A. In the group A, we have Streptococcus Pyogenes. Okay. In the group B, what we have? We have Streptococcus agalexia. Then in the group D, we have Enterococcus faecalis and faecium. Okay. And this particular one is bit controversial also. Some says it is not like that, but still it's being grouped like that. So Group A, Pyogenes, Group B, Escherichia, and Group D, Enterococcus faecalis or Faecium. And if you just want to know that what is in the Group C also, then it is Equisimilis, Streptococcus equisimilis. That particular one generates a particular substance termed as streptokinase. Okay, equisimilis is being used to produce what? This particular streptokinase. Even Pyogenes is being used to produce what? Streptokinase. And if somebody asks you more, it is by what? Equisimilis. Okay, this is what is the relevance of this. That's all. Now, remember this particular one. The Group A is Pyogenes, Group B is Escherichia, Group C is Equisimilis, and Group D is a controversial one, Enterococcus faecalis and Faecium. Is it fine? After this particular one, let's talk about the difference between Group A and Group B Strepto. Now, for your reference only, the important thing which I like to tell up, this particular question came in the INICET exam, that how to differentiate between Group A Strepto and Group B Strepto. Now, without seeing up, can you tell me the Group A Strepto is what? Group A Strepto is Streptococcus Pyogenes. Very good. Okay. And Group B Strepto is what, guys? Streptococcus Escherichia. So, while giving up this lecture, I am like thinking only that you are there sitting in front of me. So that's why I will ask in this fashion only, so that it feels that I am teaching somebody. Okay. So Group A Strepto is Streptococcus Pyogenes. Group B Strepto is Streptococcus Escherichia. Is it fine? Then how to differentiate between them? Differentiate between them on the basis of certain tests. One is the antibiotic test, that is the bacitracin test. Okay. Then you have a reaction termed as CAM test, and then you have a reaction termed as HHT test. Okay. And what is HHT test? Hippurate hydrolysis test. Hippurate hydrolysis test is HHT test. Fine. CAMP. I will tell you what is CAMP. CAMP is basically the name of 4 scientists. Now, first of all, talking about the bacitracin test. So, Streptococcus pyogenes is bacitracin sensitive. This particular one is what? It is bacitracin sensitive. And this particular one is what? Bacitracin resistant. Okay. What is the meaning? The meaning is that bacitracin kills up Streptococcus pyogenes, whereas bacitracin resistant one is which one? Escherichia. That is Streptococcus escherichia. Is it fine? Now, this was asked in the INICET exam. Regarding this CAM test, the CAM test here is the name of the 4 scientists, and the name of the 4 scientists is Christie, Atkins, Munch Peterson. Christie, Atkins, Munch Peterson. That is their CAM test. And the CAM test is negative in the case of Group A Strepto, and it is positive in the case of Group B Strepto. That you need to know first of all. Okay, I will tell you what is this CAM test later on when we study up the Streptococcus escherichia. I will show you that. Okay, regarding the HHT, Hippurate hydrolysis test. This particular Hippurate hydrolysis test, if somebody talks about, again, it is negative in the case of Streptococcus pyogenes, and this particular test is positive in the case of Streptococcus escherichia. Is it fine? So, Hippurate hydrolysis test is negative here and positive in the case of Streptococcus escherichia. And these are the 3 important tests which differentiate between Group A and Group B Strepto, and other names obviously you know, Pyogenes and escherichia. And how to remember these particular test names? So, remember them on the basis of this base camp of hippo. Okay, upside association. What is there? A base camp of what? Hippos. Hippos have a base camp. Fine. So that is bacitracin test, CAM test, and Hippurate hydrolysis test. So at least something will come in your mind when you go for the exam. Okay, guys. So first of all, we'll talk about the most important one. That is the Streptococcus pyogenes, which is also termed as Group A Strepto gas. Okay. The Streptococcus pyogenes is gram-positive cocci. What it is? It's a gram-positive cocci. And guys, if you remember up in the initial ones in the gram-positive cocci, we have flow chart. In that, the catalase positive was staph and catalase negative was strepto. So it's a gram-positive cocci which is catalase negative, and obviously coagulase does not have anything to do here, so that is obviously negative. So gram-positive cocci, catalase negative, and these particular cocci, they are obviously violet color, and these cocci, they are arranged in what? Chains. These cocci, they are arranged in what? Chains. And if somebody asks you that which is having the longest chain, which particular streptococcus is having the longest chain, the answer to this question is Streptococcus salivarius. And this particular salivarius, as the name suggests, where it is in our saliva. Okay, so this particular salivarius is in the saliva and it is having the longest chain. Remember this particular point. Coming back to Streptococcus pyogenes. The Streptococcus pyogenes, in the starting only, I like to tell you that in the Streptococcus pyogenes, if somebody asks you that how you collect the sample and where you keep it. So obviously, if a patient is suffering from pharyngitis and all, so you take the throat swab from it and you put it in a transport media. The name of the media is what? Pike's media. Okay. The name of the Streptococcus pyogenes media is what? Pike's media. Transport media, I already told you. What is the meaning of transport media? Which maintains the viability of the organism but does not allow the multiplication. That is termed as Pike's media transport one for the Streptococcus pyogenes. Okay. Then the best selective media, if somebody asks you for the Streptococcus pyogenes, is what, guys? That is CVBA. What is the name? CVBA. And what is CVBA, guys? It is crystal violet blood agar. It is crystal violet blood agar. And why we say that the crystal violet is to be used in this blood agar? Because crystal violet does what? It inhibits the staph. This particular one inhibits the staph growth. It does not allow the staphylococcus to grow. And because what we want to grow? We want to grow streptococcus. So that's why we need to inhibit the staph. And for that, you need this particular media termed as what? CVBA. Okay. And on the CVBA, the streptococcus colonies, they come and they are very, very small. And we say that what is the size of those colonies? Pinpoint size. Pinpoint size colonies are feature of Streptococcus. Okay. And important is that we are talking about a beta hemolytic strepto. So obviously it will produce a complete zone of hemolysis. So that is obvious. Okay. But the size of the colonies is very, very small, and that terms is what? Pinpoint size colonies. Is it fine? So regarding this particular culture media stuffs, we have done here itself. Besides that, we'll talk for them in the later part also. Remember one thing, that important regarding pyogenes is the various diseases. Okay. So as far as the name is concerned, okay, as far as the name is concerned, what is the name? Streptococcus pyogenes. So what comes in our mind? That it does what? Pyogenic infections. What it does? Pyogenic infections. And what are the various pyogenic infections? Okay. So let's talk about them. One is, it does acute pharyngitis. It does acute pharyngitis. The patient complains of what? Sore throat. Okay, recurrent sore throats happens in this acute pharyngitis stuff. That is being done by Streptococcus pyogenes. Besides that, if somebody asks you that in this, does the pseudomembrane can also form? Yes, pseudomembrane can definitely form, and it is what is termed as streptococcal membranous pharyngitis. Is it fine? So this is one of the point. Besides that, certain skin conditions like cellulitis, that can be done by this. Impetigo. And which sort of a impetigo, guys? This question comes, a US Assembly favorite. Impetigo, that is non-bullous. the bullous impetigo is being done by staph, and it is non-bullous impetigo. And in this only what we observe, honey colored crust. Honey colored crust around the lips and all. This particular one is there, that is termed as non-bullous impetigo. Okay. Then there is one which is termed as erysipelas. This particular ailment, erysipelas, this was asked in one of the exams. And this particular erysipelas, what we have, in this, lymphatics are involved. What is involved? Lymphatics are involved. Fine. And in this, a red color streak or a red rash can be there. And what is involved in this? Lymphatics. Is it fine? Now, besides this all cellular conditions, what else can happen in the case of skin involvement and all? So, basically, here, this can also happen. That is scarlet fever. And the scarlet fever toxin only is termed as the super antigen of Streptococcus pyogenes. That is being termed as what? The super antigen of Streptococcus pyogenes. And you know what is a super antigen? Super antigen is one which activates more than 20% of the T lymphocytes. Okay. And it attaches where? Laterally on the V beta domain. So that is important. Now, this is what is a super antigen. Which one? Toxin A and C. The other name of the same stuff is what? Pyrogenic toxin A and C. Or erythrogenic toxin A and C. This is also the same scarlet fever toxin. Besides this, what else you need to know here is this particular stuff, that it also leads to a condition termed as acute necrotizing fasciitis. Acute necrotizing fasciitis, and because of the doing of this particular stuff, it is also termed as flesh-eating bacteria. Another All India question, that which particular bacteria is termed as flesh-eating. Now here the question comes of INICET stuff, that flesh-eating necrotizing fasciitis stuff is only done by Streptococcus or Pyogenes and all that. No, it can be done by staph also. But majority is being done by what? Streptococcus Pyogenes. And that's why the name of flesh-eating bacteria is Streptococcus Pyogenes only. Okay. So this also needs to be remembered. Other than that, certain ENT stuffs, like it associates with quinsy. And what is quinsy? Peritonsillar abscess. That is what is termed as quinsy. So quinsy is being done by this particular Streptococcus Pyogenes. Okay. Now, other than that, if somebody asks you that which all other things the Streptococcus Pyogenes does, so remember this, guys, puerperal sepsis. Okay. After the pregnancy, the infection happens in the puerperal period. So that is being done by this particular Streptococcus Pyogenes. Is it fine? So these are the important pyogenic infections which are being done by the Streptococcus Pyogenes. And in them, certain ones, they are definitely being asked as a question. This one and the scarlet fever toxin ones. These are the ones which are being recently asked, and they will be asked again. Okay. Because they are important. You will need them somewhere for sure. To make your journey easy in this, let's see a mnemonic, and that mnemonic will give you some sort of easiness to remember the things done by Streptococcus pyogenes, the pyogenic infections. Now, these are the various pyogenic infections done by Streptococcus pyogenes. Okay, in a nutshell. So remember these particular names by a mnemonic: nipples. And what is there in the nipples? Necrotizing fasciitis, flesh-eating bacteria, just we have talked about. Along with that, sometimes it can cause what? Myositis, muscles inflammation. Then impetigo. Impetigo, which impetigo? Non-bullous impetigo. Which particular impetigo, guys? non-bullous impetigo, because bullous impetigo is done by staph. Then you have pharyngitis, acute pharyngitis. Most common cause of one of the sore throats bacterial causes Streptococcus pyogenes. So it associates with what, guys? Sore throat. Streptococcus pyogenes can definitely associate with pneumonia also. So it associates with pneumonia. Lymphangitis. This lymphangitis only is termed as what? Erysipelas stuff. Okay. So this particular one, which is written in the next one also. So these particular red color streak along with the lymphatic involvement, that is what is termed as lymphangitis, and that is also being done by Streptococcus pyogenes. This I already told you. A pus condition along with lymphatic involvement, erysipelas, and cellulitis, the same one, that is having a pyogenic stuff. Scarlet fever. The scarlet fever toxin, I've told you, the toxin of this particular disease behaves like a super antigen. It behaves like a what? Super antigen. And what is a super antigen? Which activates more than 20% of the T lymphocytes and lands the individual into what? Shock. Is it fine? So this particular one is important regarding the, like, if you want to remember up some of the names of the diseases done by Streptococcus pyogenes, and these are which infections? Pyogenic infections. Again, nipples, necrotizing fasciitis and myositis. I is impetigo. P is pharyngitis. P is also pneumonia. L is lymphangitis. E is erysipelas and cellulitis. S is scarlet fever. Okay. So at least something you will be able to recall up in the exams by this particular mnemonic for the Streptococcus, that is the nipples. Is it fine? Now coming to the non-pyogenic infections. Okay. Guys, important is that what are the various non-suppurative complications? Okay, non-suppurative complications of Streptococcus pyogenes is itself a question. And what is that? ARF and AGN. What is that? ARF and AGN. ARF stands for acute rheumatic fever. Okay, acute rheumatic fever. AGN stands for acute glomerulonephritis. Okay, acute glomerulonephritis is AGN. You must be remembering up in the second year, these are the two questions which comes in a short note or in a long question, that what are the non-suppurative complications of Streptococcus pyogenes? Because everybody knows by the name itself that it will does what? Pyogenic infections. But important is the non-suppurative complications. And what are those? Acute rheumatic fever and acute glomerulonephritis. In the case of acute rheumatic fever, the patient comes with what? Please tell. Sore throat. Okay. The patient comes with recurrent sore throats. Unexplained. Why again and again sore throat is happening up? Okay, so recurrent sore throats happens in this particular one. Whereas in this, there is a history of what, guys? History of pyodermic infection. In this side, what is there? The history of pyodermic infection in the case of acute glomerulonephritis. Acute glomerulonephritis. So in one, there is a recurrent sore throats. Another is history of pyodermic infection. Means some skin infection happens of pus and later on the kidneys got involved. That is what is termed as acute glomerulonephritis after this pyodermic stuff. Okay. But some says that it is only pyodermic only. No, it is not so. It can be after the sore throat also, this particular glomerulonephritis. And if I ask you which one is more serious affair, acute rheumatic fever or acute GN? The obviously answer is acute rheumatic fever is more dangerous than the acute GN. Now one thing you can ask up, sir, like something is happening in the throat and why the heart is being involved up? So this is what is termed as, guys, molecular mimicry. Okay, this is what is termed as molecular mimicry. And molecular mimicry is what? Molecular mimicry is this, that certain cellular components of this Streptococcus pyogenes, they cross-react with the heart. And what is that? You must be remembering up, na? C, carbohydrate C. It cross-reacts with cardiac walls. And the M, that is M protein, it cross-reacts with myocardium. And they cause this damage. And this phenomena is termed as what, guys? Molecular mimicry. What do you call them as? Molecular mimicry. So remember this particular one, that what is termed as molecular mimicry, the cross reaction between the organism and the organ. Is it fine? Now, after this particular one, what else is the difference between ARF and AGN? Now, whenever these types of infection happens, there is induced an immune response. And the immune response induced in the case of acute rheumatic fever is marked. Marked immune response is there. Whereas in this side it is mild to moderate. In this side it is what? Mild to moderate immune response. And guys, you know that whenever the immune response is being induced up, what happens to the complement levels? The complement levels, they decrease. Complement levels, they decrease whenever an immune response happens. But interestingly, the complement levels remains normal in the case of ARF, whereas in the case of AGN, the complement levels, they decrease for some time and after that come back to normal. Okay, after that they come back to what? Normal. So this you need to remember. Now, besides that, what else you need to know here? The other important thing is that in which there is a lifelong prophylaxis needed. So lifelong prophylaxis of penicillin is indicated up in the case of ARF, okay? Whereas in the case of AGN, what happens? There is a spontaneous remission, okay? There is a spontaneous recovery in the case of AGN. Means it happens like this, that the person had nothing before. So that sort of thing happens in the acute GN. In the case of ARF, it is being said now that they don't have much of a role to have the titers of ASO. So ASO titers are being looked out in the case of ARF. And what is ASO? ASO stands for anti-streptolysino. Okay. Anti-streptolysino titers. They previously were the supporting criteria in the case of zones, but now they are being excluded up. But still you should know that which particular titers we can go in the case of acute rheumatic fever. Answer is ASO. But now they have significantly lost their relevance. ASO titers more than 200 TOD units. That is might be related with acute rheumatic fever. Okay, so it doesn't have a confirmation, just a particular presumptive stuff that it might be what? It might be a acute rheumatic fever. Whereas in the case of this particular one, that is the acute glomerulonephritis, you have which particular titers to go for? Anti-DNase B. Which particular titers? Anti-DNase B more than 300 to 350 units. And this was asked in one of the exams. And that you should know. Is it fine? So remember, these are the differences between ARF and AGN, which are frequently asked even in your second year. This is a favorite question, and even in the exam also, this is the favorite question examiner, in which the complements level increase, in which it decrease, in which it remains normal. So that sort of thing you should know. Okay, what is the history in what, in which lifelong prophylaxis is there, which is a recovery. So I suppose by this particular differences between them, you can easily make out that which one is having what. And this is a favorite question, that post-Streptococcal glomerulonephritis, this particular one is which hypersensitivity. So basically immune complexes, they are formed up in this. So this is a type 3 hypersensitivity, guys. It is which hypersensitivity? It is type 3 hypersensitivity. And what is type 3 hypersensitivity? Immune complex mediated. Immune complex mediated, that is the type 3 post-Streptococcal glomerulonephritis. So again, if we see up this particular table, there is a history of recurrent sore throats in the case of ARF. AGN, history of epidemic infections. Immune response is marked here, even though the immune response is marked, but the complement levels remains what? Normal. Whereas in the case of GN, mild to moderate immune response is there, but the complements, they decrease for some time, thereby comes back to normal. Whereas in this, there is spontaneous recovery, and lifelong prophylaxis with penicillin is indicated in the case of this particular acute rheumatic fever. Whereas the ASO titers you look out in the case of this particular one more than 200 tod units, and whereas in this side it is anti-DNase B titers more than 300 to 350 units. Is it fine? So this you need to remember regarding the difference between these non-suppurative complications of Streptococcus pyogenes. Okay, so this is the table of Harrison, and in this, as you can see, that the rheumatic fever without carditis, for this particular one, you see the time of the medication of this penicillin as prophylaxis for 5 years after the last attack or 21 years of age, whichever is longer. So that is the time period for the rheumatic fever without carditis. Now the rheumatic fever with carditis but no residual valvular disease, for that what it is, 10 years after the last attack, and this particular thing is or actually. So 10 years of after the last attack or 21 years of age, whichever is longer. Okay, previously it was 5 years and 21 years, and now it is 10 and 21. But the change is rheumatic fever is with what? Carditis. Besides that, the rheumatic fever with persistent valvular disease, evident clinically or on echocardiography, means you have gone for echo. In that also it's evident that there is a persistent valvular disease. For this, you need for 10 years after the last attack, this is okay, or 40 years of age, whichever is longer. Sometimes lifelong prophylaxis is needed in this particular case, to be very precise. Okay. So without carditis, it is up to 5 years after the last attack or 21 years of age. For rheumatic fever with carditis, 10 years after the last attack or 21 years of age. Rheumatic fever with persistent valvular disease evident clinically or on echocardiography, it is again 10 years after the last attack or 40 years of age, whichever is longer. Sometimes lifelong prophylaxis. So this is like, because on this the question came, so that's why I like to tell up here itself that without carditis this much, with carditis this much, a persistent valvular disease this much. Is it fine? So now coming back to the Streptococcus, talking now regarding the GBS. Okay, and you know GBS stands for what, guys? Group B Strepto. It stands for what? Group B Strepto, and the other name is what? Streptococcus agalactia or agalactia. Now, first of all, what you need to know regarding this particular bacteria, it's a normal commensal. Okay, it's a normal commensal of birth canal. Not in every female, but in some. Okay, and while child is passing through this birth canal, acquires the infection of this particular bacteria and lands up with what? Either the early or late neonatal meningitis. Okay, early or late neonatal meningitis is being done by this particular group B strepto, that is Streptococcus agalactia. And in fact, I should say, if somebody asks you the most common cause of neonatal meningitis in the world, the answer is Streptococcus agalactia. So that you need to remember first of all. Besides that, this particular one, GBS, group B strepto, can also do certain other infections. Okay, like it can associate with the endocarditis also sometimes, rarely, but it can. Okay, it associates with the even sepsis. It is one of the common causes of neonatal sepsis. So that is also there. Neonatal sepsis is also being done by this particular GBS, and in fact this is one of the common causes of that neonatal sepsis. So all these particular things are done by this GBS. Along with that, what you need to know, I've already told you also in the starting itself, that which particular important test is done to diagnose this one. The answer is CAM test. And what is the full form of CAM, guys? Christie-Atkins-Munch-Peterson. What is the full form? Christie-Atkins-Munch-Peterson. So now talking about the CAM test. And what is the CAM test? Suppose you take up blood agar. Okay. And in this, in the center, you have done the streak of Staph aureus. In the center, what you have done? you have done the streak of Staph aureus. And as you know, the Staph aureus is what? Beta hemolytic. Then you have made up 2 streaks like this and like this. Okay. And what you observe after 1 day, that when this particular streak mixes up with this Staph aureus streak, there is a enhancement in the zone of beta hemolysis, which comes in the form of an arrow. Okay. So basically, you know, Staph aureus is what? Beta hemolytic. And this particular one, that is the first one, is what? It is a, like, let's see what it is. Is it group A strepto, group B strepto? So this one is group B strepto. Okay. Whereas this one is group A strepto, because when this streak mixes up with this particular streak of Staph aureus, there is no enhancement in the zone of beta hemolysis. Okay. So let me make you understand this, or what is happening here. So what is happening, guys, you know, the CAM test is devised by 4 scientists, Christie, Atkins, Munch, Peterson. What they have seen up, then in the center, when you do the streak of Staph aureus, so beta hemolysis around this particular streak will be shown how? Like this particular type of hemolysis zone will come around it. What happens in this group B strepto? This one also comes like this, and this one also comes like this, but this hemolysis enhances whenever this touches up this particular streak of Staph aureus. Which one? The group B strepto. Now, when the group B strepto touches up the Staph aureus, there is an enhancement seen. Why this enhancement seen? So as per these CAM fellows, what is there? That there is a release of a factor, and name of that factor is what? CAM factor. And because of this CAM factor, there is an enhancement whenever the group B strepto touches up the Staph aureus. Whereas the same thing does not happen when the group A strepto touches up the Staph aureus. So this is what is termed as CAM test positive. Okay, and this is obviously CAM test negative. So that enhancement of beta hemolysis does not happen in the case of group A strepto, that is Streptococcus pyogenes, but it does happen in the case of group B strepto. Is it fine? So this is what is termed as CAM test. And another one which is there, that is termed as hippurate hydrolysis test, that is also there. The hippurate hydrolysis test, that is also there, positive. In this particular one, it hydrolyzes this particular amino acid, hippurate. So hippurate hydrolysis test is also positive in the case of group B strepto. And as you have seen up, in the starting only I have told you that this one is found to be bacitracin resistant. This one is found to be what? This one is found to be bacitracin resistant. Okay. The bacitracin does not act upon the Streptococcus agalactia. And this question asked. This question was there in the NEET PG, that they have given up a case scenario of the meningitis, and in that the second last line was showing up that it is found to be bacitracin resistant. Okay, and it's a cocci, a gram-positive cocci. Name the organism. Organism is Streptococcus agalactia. Is it fine, guys? So remember, this is what is the importance of knowing of these particular tests. Now, talking about the Enterococcus. Talking about the Enterococcus. Enterococcus faecalis and faecium. These two names you need to know. One is faecalis and one faecium. As such, they are the normal commensals of our gut. Okay, they are the normal commensals of our gut. Okay, even you and me is also holding a what? Enterococcus faecalis and faecium in our gut. But as such, they don't do much to us. But whenever they get a chance to affect us, they do severe infections. Means somebody is doing some gut surgery and they could able to contaminate that. It is not easy to treat it. So that is what is the problem. So basically, Enterococcus faecalis and faecium, what they do surgical wound infections. Okay. Other than that, they associates with going up in IV drug abusers, left-sided valve endocarditis. Left-sided valve endocarditis is also being done by this particular Enterococcus. Okay, both of them they ask questions. Now, why they have become so relevant now? The problem is, as such, they were normal commensals, but they have the property to recruit the resistance in them by various means. Okay, and because of this property only, they are becoming day by day resistant to number of things. Fine. So first of all, you should know regarding the disease part that they does these all things. Besides this, you should know that in the lab diagnosis, okay, suppose from the surgical wound infections you have taken the pus, okay, from this you have gone for the blood culture and all. So in the lab diagnosis, remember the culture media for this is a asked question, and the culture media is what? Bile esculin agar. This is the culture media for this particular one, bile esculin agar. And this particular bile esculin agar produces of which sort of colonies? Black colored colonies. Okay, black colored colonies they come on this media, bile esculin agar of Enterococcus. Either it can be fecalis, it can be faecium. Both it can be. Okay, so black colored colonies they come of this particular Enterococcus on bile esculin agar. And when you do the gram staining of them, what happens when you do the gram staining of them? The gram staining of them, it's a gram positive cocci. So it will look like which color, guys? Violet color. So violet colored spectacle-like appearance. Okay, violet color spectacle-like appearance happens to be of this particular bacteria in the gram staining. Okay, spectacle-like. Then, other than that, if I ask up regarding the drug of choice for these Enterococcus, then what is drug of choice? The drug of choice is a combination of penicillin group, that is ampicillin, along with aminoglycosides like gentamicin. Okay, so this combination of ampicillin and aminoglycoside, mostly the gentamicin, is properly being used for these Enterococcus, and they have a synergistic effect. What they have? Synergistic effect. They have a synergistic effect that you need to know. Besides that, what you else need to know regarding it is that nowadays they have acquired the resistance against this combination. So you should know that what is the second line drug also with you. The second line drug with you is vancomycin. The second line drug with you is what? Vancomycin. And they are so notorious bacteria that they have started resistance against vancomycin also. And now they are termed as VRE. And how they have become VRE? They have brought the change in the cell wall structure. Okay, and what is the change in the cell wall structure? D-alanine. D-alanine changes up into D-alanine D-lactate or D-alanine D-serine. Okay, D-alanine D-lactate or D-alanine D-serine. This might be the change in the cellular structure from the alanine to the serine or to the lactate. This was also being asked in one of the exams, that what exactly the change happens whenever a simple Enterococcus have turned into VRE. This is the change in the cell wall structure of it. D-alanine to D-alanine D-lactate, D-alanine D-serine. Is it fine? And what they have become because of that? VRE. And what is the drug of choice for this VRE now? Answer is linezolid or daptomycin. Linezolid or daptomycin can be used for this VRE. And how does they have become VRE, guys? How does they able to do this particular change? From somewhere they have got a gene, and that gene name is what? VAN gene. Okay. And the interesting aspect, that is what I like to tell you that this VAN gene, these particular VRE, they have given up to the Staph aureus also. So up till now, you must be knowing of MRSA, MRSA, methicillin-resistant Staph aureus. But now they have also changed into what? Varsha. And what is Varsha? Vancomycin-resistant Staph aureus. And for them also, what he will use, guys? Linezolid or daptomycin. Is it fine? So this is what is the logic, because they are normal nosocomial infections which are there in the hospitals. So that's why the treatment chart is important for us, and we should know that these normal commensals are becoming what? Day by day resistant to vancomycin. Okay. And they are using up our reserve drugs also. So that particular thing is very important to know regarding the Enterococcus, and they have that property which is a problem for the future generations. Is it fine? Even though they are normal commensals, another aspect. Okay. So this is regarding the Enterococcus, which you should know. Besides this, now talking about the alpha hemolytic fellows, and in the alpha hemolytic ones, we have, which shows alpha hemolysis, that is alpha hemolytics, we have the family viridans. Okay. And in the viridans, what comes? Streptococcus viridans. Okay. And what else comes? Streptococcus sanguis or Streptococcus mutans. These names you should know, they are in the viridans group. So the viridans group name is there. The group is viridans, and it is having the Streptococcus viridans and sanguis or mutans. Now, this particular Streptococcus viridans associates with what? Sabe. Okay, this particular one associates with what? Sabe, that is subacute bacterial endocarditis. And in fact, I should say this is the most common cause of Sabe. Which one? The Streptococcus viridans. Besides that, what else you need to know regarding Streptococcus viridans? You need to know regarding this particular one, that is the Streptococcus viridans, some other aspects also, that this associates with late onset prosthetic valve endocarditis. Means the cardiac surgeon have changed somebody's valves and put up the prosthetic valves, and they also got damaged. After 1 year of replacement, that is termed as what? Late onset prosthetic valve endocarditis. So can you tell me the early onset was done by? That is being done by Staph epidermidis. That is less than 1 year. And what about the ABE, acute bacterial endocarditis? That is being done by Staph aureus. Okay. And regarding this, sanguis and mutants, if somebody asks regarding sanguis and mutants, this one associates with dental caries. This one associates with what, guys? Dental caries. And if both the options comes, then the better answer is mutants, which associates more commonly with the dental caries. Now here, the case scenario which can come in your exam is that after this particular dental caries stuff, okay, somebody have gone to the dental surgeon for a RCT, root canal treatment, and dislodgement happens in the RCT. You must, if at all somebody have gone under this particular RCT, they must be knowing up that they put up the things and they try to dislodge. So after having this dental surgery, a person developed spikes of fever. Okay, a high grade fever happened, and when the physician happens to see up the patient properly by examination, he could able to appreciate a murmur is also coming up. So guys, what have happened to the patient after 2 to 3 weeks? So answer to this question is, after this dental surgery, if these all features are coming up, means the patient is having what, guys? Endocarditis. The patient is having what? Endocarditis. So remember this particular aspect, that after the dental surgery, endocarditis have happened up, and this endocarditis, as you know, just now I told up, having a fever along with murmur. These are the special features which happens to be after this dental surgery. So whenever they talk about this, you should think for viridans group, and a viridans group also regarding which fellows? Streptococcus, sanguis and mutants. Mutants more than the sanguis. Is it fine? So this is clear. Now this you already know that which is the criteria for endocarditis, modified Duke's criteria. What is the major criteria? The major criteria is blood culture of the typical organisms, okay, and along with that echocardiography. In that you can see the vegetations. That is the major criteria. And what about the minor criteria, guys? In the minor criteria, you have those particular ones like fever, okay, immunological phenomena, embolic phenomena, okay. So those particular ones, along with that microbiological criteria, that you are not getting the typical organisms in the culture, but still you are getting it. So these all vascular phenomena, these all is indication of what? Endocarditis. You must be remembering now all those rod spots, oscillus nodes, glomerulonephritis, these all particular features along with Janeway's lesions. So these all they observed as a minor criteria of it, and that is modified Dukes. You must be knowing that. Besides this, how many blood cultures should be done? Here only if we want to discuss that how many blood cultures should be done. So remember guys, 3 sets of blood culture is preferred, because more the blood culture set you will do, more is the yield of the organism. So 3 sets of blood culture is being done for this particular endocarditis. And sets means what? That one bottle in which you will put the blood is aerobic and another is anaerobic. Okay. And mostly nowadays, the ratio is what? 1:5. When you try to grow them up, you have suppose 5 ml of blood, you will put 5 times the other one. That is 25 ml. That is the culture broth. And the same thing for the anaerobic stuff also. Before it was 1:10, but now it is 1:5. The ratio means if you are taking 5 ml of blood, then you have to take up 25 ml of culture broth. And it culture broth can be what? BHI. Brain heart infusion broth. It can be glucose broth also. BHI is preferred. So this is there. 3 sets means in total 6 bottles. And they do say this preferably that this particular blood you should take from different sites, and it should be 1 hour apart. It should be what? 1 hour apart, this particular blood collection from the different sites. Is it fine? So remember this particular aspect that it should be from different sites, 1 hour apart, and you need to have 3 sets of blood culture bottles. Okay. Now, some says that can we go for 2 sets also? Yes. 2 sets of blood culture can also be done, and that is 12 hours apart. 12 hours apart you can go, and 2 sets means 4 in bottles, means 2 for aerobic and 2 for anaerobic. Okay, in that also if the organism grows up, that is also fair enough. But this is a rule that more the sets of blood culture, more is the probability of getting up the organism in the culture. Is it fine? So that's why we try to have the 3 sets. But if it is not given in the option itself, then answer is 2 sets of blood culture can also be done for the endocarditis stuff. So guys, you must be remembering now that the criteria is modified Dukes, major, minor, along with this 3 sets of blood culture. Okay, and what is the ratio? 1:5. If it is 5 ml, 25 ml of culture broth, preferably BHI, or it can be something else also like glucose broth and all. Is it fine, guys? So this is the way regarding the endocarditis you have to answer up. And if I ask you just now, like in a rapid manner, can you tell me that which is the most common cause of acute bacterial endocarditis? Very right, Staph aureus. The most common cause of SABE? Viridans. IV drug abuse are overall most common? Staph aureus. IV drug abuse are right-sided? Staph aureus. Left-sided? Enterococcus. Okay. Early onset prostatic valve endocarditis? Epidermidis. Late onset? Viridans. Okay. And after the dental caries, if somebody talks about the carditis stuff and all, endocarditis, sanguis and mutans. These names you should remember. In that also more is mutants. Is it fine? And here only I'm telling up a mnemonic to you that bio. Bio is negative for which particular group? For viridans group. Bio is negative for which particular group? Viridans group. I will tell you bio is what later when we do the pneumococcus. But you remember here, then bio is negative for which particular group? Viridans group, because on this also they have given up a question. Is it fine, guys? So these are the various streptococcus on which you need to focus upon to answer up most of the queries regarding the streptococcus. Is it fine? After that, we'll talk about the Streptococcus pneumoniae, that is also being termed as Pneumococcus. After this Streptococcus, now let's talk about the another one, which is the alpha hemolytic strepto only, that is Streptococcus pneumoniae. As such, they consider it a part of that stuff only, but still you consider it as differently. And what comes in this is Pneumococcus. The another name is what? Streptococcus pneumoniae, Pneumococcus. Now, guys, talking about Pneumococcus, you know that this is a gram-positive cocci. Okay, it is catalase negative because it belongs to Streptococcus stuff. No logic of coagulase and all here. This particular organism, Streptococcus pneumoniae, is having a particular shape. And what is that shape termed as? Lanceolate shape. And what is lanceolate? Lanceolate is flame shape. It looks like a candle flame. Okay, it looks like a candle flame. Besides that, it is capsulated. Another favorite question of examiner. And the capsule is made up of polysaccharide. The capsule of it is made up of polysaccharide. So this particular one is flame shape and it is capsulated, and the capsule is made up of what? Polysaccharide in this particular one. Important to know here is that this particular capsule is being demonstrated by a reaction termed as QBank reaction. And if you have seen up the starting video of mine, I have told up regarding the QBank reaction. Lung means pneumo. It is seen in Pneumococcus. And basically what it is, guys, it is the capsular swelling. What it is? It is the capsular swelling. And basically it's a serological reaction between capsular antigen and antibody, which leads to this breakage of the bonds, polysaccharide bonds, and thereby what happens? Capsular swelling. We just now have got to know that most of the capsules are made of what? Polysaccharide, except the bacillus anthracis, which is made up of polypeptide. Yes or no? The QBank reaction is for that only. It's a serological reaction. Why we call it as a serological reaction? Because it is capsular antigen antibody stuff. It is capsular antigen antibody stuff. Is it fine? So this you need to know. Besides that, this particular one on blood agar and chocolate agar produces Draughtsman-like colonies. Draughtsman-like appearance of the colonies, and that is termed as what? Carom coin-like. That is termed as what? Carom coin-like or Draughtsman-like appearance. Okay, so this also needs to remember regarding the colony shapes of it. It looks like a carom coin, somewhere depressed, somewhere elevated. That is what is termed as Draughtsman-like appearance. Is it fine? And this happens to be, why this carom coin-like appearance happens to be there? It is due to a particular enzyme which is being released up, termed as autolysin, amidase enzyme, because of which this elevation depression comes in the colonies. Okay, that is what is termed as carom coin-like appearance. This particular Streptococcus pneumoniae, I have just told up in the previous ones that viridans is bio-negative. Streptococcus pneumoniae is bio-positive. Now you should know what is this bio, why it is coming again and again, because there are important pairs of reaction. A lot of questions they come around them. So you should know that what is this? That is bile solubility. I is illolin fermenter and O is Optochin sensitivity. Okay, O is Optochin sensitivity. So this particular Streptococcus pneumoniae is bile soluble, illolin fermenter and Optochin sensitive. Okay, means it is positive for all these reactions. It is soluble in bile, positive. Inulin fermenter, it ferments this polysaccharide, inulin. Optochin sensitive, optochin means it's a drug, 2-ethyl hydrocuprin. It is sensitive to that, it is positive for that. And now you understand what I've told you. Then bio-negative is for what? The bio-negative is for viridans. And what is this bio-negative, guys? That is bile insoluble. Viridans is bile insoluble. Inulin non-fermenter. Optochin resistant. Optochin resistant. So that is what is the logic of these biochemical reactions, which we remember by a mnemonic bio. Is it fine? So this you need to know. On the basis of capsular polysaccharide. Okay, just now we have done that it is made up of polysaccharide. On the basis of these capsular polysaccharides, we divide up this particular pneumococcus into 90 types. And there is a special type that is termed as S, specific soluble substance based typing. Okay, specific soluble substance based typing, and that is in short terms termed as what? S typing. S typing. Okay, so specific soluble substance based typing, also termed as S typing, is used to classify this pneumococcus into how many types? 90 types. So this is a different sort of a thing, can be asked in the exam. The S typing is done for what? The answer is pneumococcus. It is done for pneumococcus. Fine. After this particular one, you should know that which all diseases pneumococcus does. Okay. And as far as the disease is concerned, it associates with these particular diseases termed as COMS. And what is there in the COMS? C is conjunctivitis. Okay. O is otitis media. M is meningitis. P is pneumonia. And S is sinusitis. Okay. S is what? S is sinusitis. So these are there: conjunctivitis, otitis media, meningitis, pneumonia, and sinusitis. Remember them by mnemonic COMS. Okay. Now talking about the meningitis first. Pneumococcus is the most common cause of meningitis in most of the age groups. Okay. In most of the age groups, this particular one, pneumococcus, is the most common cause, except the neonates. And you know, in the neonates, which is there? Group B Streptococcus agalactia. Fine. Then, if we talk about the pneumonia part, the most common cause of pneumonia in, what do you say, in HIV positive individual. If somebody asks you this, so answer to this question is what, guys? Pneumococcus. Okay. Recently asked question. Most common cause of CAP. What is CAP? Community acquired pneumonia. Community acquired pneumonia. The most common cause of CAP is pneumococcus. Okay. If somebody asks you that what is the most common cause of lobar pneumonia, in which lobes are involved, also termed as typical pneumonia or lobar pneumonia, the answer to that question is what? Lobar pneumonia. So that is again pneumococcus. If somebody asks you that most common cause of atypical pneumonia, answer to this question is Mycoplasma pneumoniae. Mycoplasma pneumonia, and the pneumonia done by this is also termed as walking pneumonia. Now, if I ask you that which is the most common cause of pneumonia in HIV positive, up till the answer is what? Pneumococcus. But if I write up this, when the CD4 count falls below 200, then which is the most common cause of pneumonia? Our answer changes to Pneumocystis cerevisiae. Okay, our answer changes to what? Pneumocystis cerevisiae, also termed as Carney. Is it fine, guys? So these are all sorts of questions which can come regarding the pneumonia stuff. Again, if you revise up, if somebody asks you most common cause of pneumonia in HIV positive, pneumococcus, recently asked question. The most common cause of CAP, community acquired pneumonia, answer is pneumococcus. Most common cause of typical lobar pneumonia, pneumococcus. Most common cause of atypical pneumonia, another recently asked in the exam. So we should know here itself in this particular list. The answer is Mycoplasma pneumoniae. And the most common cause of pneumonia in HIV positive and CD4 count is less than 200. That is Pneumocystis cerevisiae. That is Pneumocystis cerevisiae or Pneumocystis carni. And this is which sort of pneumonia? This is atypical pneumonia. Lobes are not involved. Remember this. Okay. So this much you need to know regarding the disease part of it. And if we talk about the drug of choice for this pneumococcus, the answer in the Harrison is still what? Penicillin. You can use cephalosporins also, but still, as per the Harrison, it is answer is penicillin. And in this, there is this mechanism which gets into action. PBP changes to PBP2B. This particular thing changes up for the resistance. Okay, because of this penicillin binding protein changing to penicillin binding protein 2B, this particular change happens to be here, because of which the resistance is increasing against penicillin in pneumococcus. That also you need to remember. And can you tell me PBP change to PBP2A is where? Answer is MRSA. Okay, the answer to that question is what? MRSA. Now, if we talk about the vaccine part of it, the vaccine of pneumococcus. The vaccine of pneumococcus previously, which used to come is 23-valent polysaccharide vaccine. 23-valent polysaccharide vaccine was first to come, and it is being given to whom? Not to the children, at least. It is being given to splenectomized individuals, because whenever the spleen is being removed, then they becomes more prone for capsulated organisms. The splenectomized individuals, they are prone for capsulated organism infections, and one of the common infections is of pneumococcus. That's why you need to give this particular vaccine to these splenectomized individuals. And other than that, 13-valent conjugate vaccine, which comes by the name of Prevnar, is now being given up in the children at various stuff like 2 months, 4 months, and 6 months. So 13-valent conjugate vaccine of pneumococcus is also available, and it comes by the name of what? Prevnar. Another important thing is, whenever we are going for surgeries, like in the less than 2 years of child, like that particular one going for cochlear implant, we know the cochlear implant is to be done before 2 years for the proper speech development. Okay, or suppose this particular child is of hydrocephalus and you need to put the CSF shunts. So regarding the CSF shunt surgeries for the hydrocephalus, you need to give this pneumococcal vaccine. You need to give in these what? Pneumococcal vaccine before the surgery. Okay, before the surgery, they definitely need what? Pneumococcal vaccine. Is it fine? So that also needs to remember. So these are the very important points regarding the pneumococcus, a question which comes mostly in several exams. And important to know is that it's a gram-positive cocci and it's a streptococcus, that's why it is catalase negative. Carom coin appearance, okay, due to that autolysin enzyme. That is also one of the important things which you should know. Okay, so this much is there in the gram-positive cocci, which you should know. And along with that, I like to show you some pictures now. And those particular pictures, they are there in this. That is the gram stain picture of Streptococcus. And the gram stain picture of Streptococcus obviously will be of which particular color? It will be violet color because it is a gram-positive cocci. Yes or no? So, and they are in chains. Now guys, can you tell me which is having the longest chain? The longest chain which is there in them is of Streptococcus salivarius, and mostly cocci which are in chains are Streptococcus. This was the decitrescent testing which was used for Streptococcus pyogenes and Escherichia differentiation. This is that, and as you can see around this zone is coming up, okay, and you're growing it on what? You're growing it on MHA, and MHA is having what? Blood. So basically this particular antibiotic testing, as such we say na, that we do the antibiotic testing on MHA, but here is what? That you have to add the blood because you want to grow up which colonies? Streptococcus. Then only it will be able to perform this test. Or you can directly do this test on blood agar. This question can come. That which is an exception to that Kirby-Boyer disk diffusion testing, in which we do not do it on MHA, we can do it on blood agar. This is that exception because otherwise Streptococcus will not grow only. And you must be knowing of those particular names, that base camp of Hippo. Got my point? Now, regarding the bile esculin test, this is the bile esculin test. Pyogenes gives it negative and it changes to the positive one. And I've already told the black colored colonies they come in this particular bile esculin agar or test. CAM test, which we have discussed up also. As you can see that there is one A and one is like another one is B, because this particular thing creates a confusion in the mind. So instead of A and B, let's have the 1 and 2. Okay, let's have the 1 and 2 instead of A and B. Now, I've told her that the CAM test is performed on which particular media? Blood agar. And as you can see, the first streak, when it meets up with this particular Staph aureus streak, there is an enhancement in the zone of beta hemolysis, and this is termed as CAM test positive. Whereas this particular one meets up the Staph aureus, there is no enhancement in the zone of hemolysis. So this particular one, CAM test, is coming positive in this because there is an arrowhead which is being formed. And this particular arrowhead which you observe in this is termed as enhancement of the zone of hemolysis. This is termed as what? Enhanced zone of hemolysis. And this is CAM test positivity. This is termed as what? CAM test positivity. Is it fine? And I've already told you why this enhancement happens, because of the factor release. Which particular factor? The CAMP factor. Okay, the CAMP factor. And this is what is termed as Christie-Atkins-Munch-Peterson testing. Now, just now we have seen Streptococcus pneumoniae. That is the pneumococcus. This is a picture of it. Okay, and they are in pairs. See this, they are in pairs. They love to be within pairs. They are diplococci and they are gram positive, and they have a capsule, and that capsule reaction also I've told you again and again, Q-lung reaction, which is a capsular delineation or capsular swelling which happens due to the capsular antigen antibody interaction. Is it fine, guys? Now, my dear friends, Optochin sensitivity, if we talk about the Optochin sensitivity, I told you that is a drug, 2-ethyl hydrocuprin, and the pneumococcus on blood agar showing alpha hemolysis, that is partial, with sensitivity to this Optochin disc. If you remember off, I have already told you that bio is positive. Bio positive means it is bile soluble, inulin fermenter, and Optochin sensitive. And as you can see, the zone of inhibition is coming off. That is what is termed as Optochin sensitivity. Is it fine? So this much is there regarding the pictures in the pneumococcus along with the other streptococcus which you have observed. Fine.